Good morning. Time for posing, then we'll start the session. Good. So, yeah, very warm welcome to all. Yesterday I was talking to a resident. 10 years back when we are starting the residency or just finishing the residency, the kind of questions we would put forward to our seniors were how to shape our career. Is there a prospect for the specialty as such? So these were the kind of questions we would ask our seniors. The resident asked me, "Sir, can I get a job?" This is the first question actually. Second, can I work near home? So we'll try to address these two questions and many more in this session. So we have two of our most eminent panelists here. Jayaprakash Madhavan sir has started his career in health service, then moved on to RCC, and then he has spearheaded a center from scratch at KIMS Cancer Center. Dr. Shami Chandran. Dr. Shamir has a global experience, has worked in Kerala, in Brunei, and he was in the NHS, and now he's back in Kerala. So very warm welcome to all. My dear friends, colleagues, juniors, welcome. That's that. So the question is, every year we have 30 students passing out, and 10 to 15 Kerala students passing out from other states who wants to come back to Kerala. Is there a space for everyone? What do you think? Can you please raise your hands? Those who are sure about getting a job in Kerala, please raise your hand. I would like to have the opinions of the house here. Please raise your hands if you are sure that you will get a job in Kerala. Or at least in India. Okay, fine, good. Thanks. Okay. So, what do you think?
In Kerala, and there are 70,000 new cancer patients are there, and cancer prevalence will be over 4 times of that. Patients are there in Kerala. So as he said, there was 40 people are coming every year, and if everybody is coming to Kerala, there is not much places there. Now at present we have got 40 Linacs and 6 or 7 cobalt machines are there. There is a scope for further treatment is there. Improvement is there. So soon we are going into Trivandrum, we are going to get another 2 bunkers. Aster is coming. Then PRS with the Carcinos, they are getting another linear accelerator. And we are going to move to Perindalman also we are setting up one hospital for oncology, Al-Shifa hospital. Then Nagargoil recently we had one hospital started with LCO and one consultant is there. The scope is there. If you want to be in the home place, it's difficult. But if in India itself, there is a lot of deficiencies there. And the cancer cases incidence varies between different places. And the high incidence of cancer is there in the northeastern region and the western coast also, developed areas. The higher incidence is there. But in rural areas, and the cancer incidence is less, and the resources in, other than Kerala, the resources are mainly distributed only in the large cities. That's the main problem.
Are there enough vacancies if somebody wants to do a senior residency? Are there enough vacancies if somebody wants to do a senior residency?
Not much. Then after the passing your MD, what are the chances you are having? There are many options are there. If you want to go for a teaching profession, a senior residency should be done. Otherwise, it's not necessary. You can say, you can work as a consultant also. You can start from the scratch. You can move to some other hospital, work there, improve there, and go to that. That way you can do it. If you want to go outside, it's okay, fine. We do not waste. You can go to other countries. You can get it. For that, you have to improve the CV. After you can attend the reputed hospitals for a training, fellowships, and you need not be a 6 year or a 1 year. Even 1 month is good enough. Working in another hospital, that will give him increase your experience. And another thing is now being an ARI member, you can take membership in the other organization, Astro, and Astro also you can take membership. That gives an additional thing. And you can write the exam. In our times, There was no first year examination in India or any place. If you want to go to US, you have to go to Philippines and write the examination there. Or you have to go to UK. And then only you can. Now things have changed. If you get a foreign degree, your employability increases. And the oncology training is a global training. We are not trained for Kerala people. It's a global training. So after
like
passing,
sir,
it should be employable anywhere in the world.
sir, so like sir said, after passing out, you can either look for a private job or a senior residency in an institution. So it's your choice which way you want to move. The thing is that you should have a clarity on your own, which way you want to move. You can try out different things, that's absolutely fine. Be brave to take risk. That's the only time you can take risk actually. After 5 years, you will have family, you will have other things to take care of. You won't be in a position to try out these things. Whatever you want to try out, do it right after you pass out. Do senior residency, try out in a government setup, try out whatever there is in a private setup. If you want to set up something, do that. These are the times when we can actually make mistakes. Nobody is going to forgive you 5 years from then. If you have a 5 years experience, nobody is going to tolerate even a very silly mistake. Whatever you want to try it straight away after you pass on. So then there is the option of fellowships.
Dr.
Fellowship.
Mil, can I just interrupt in between? Like yesterday we were discussing in the cancer policy, there are 24 cancer centers in the state. So all those centers to treat radical, if they want to go for radical treatments, every center has only one oncologist to the max.
Yeah.
It's not possible to treat all toxicities. Actually, there is job opportunity in all these 24 cancer centers. So what can we do about it? They can take a contract basis also, no?
Absolutely. The thing is
that's
that actually
something we can
government
apply for, no?
Absolutely. That's something Arrow can take up and put it forward to the government actually. Many of the time, the vacancies are not completely filled by the government for the sake of financial reasons, nothing else. So this is something Arrow can take up and put a policy, make it part of the policy and pitch it to the government to fill up all of the vacancies. That's absolutely right.
Employment there are employment if you want to get in a medical college service. At present, only government setup is there. Service conditions are very fixed. Once you join that's a good thing. Go on to the top without any interruption. In cancer centers like regional cancer center or Malabar cancer, Cochin cancer center, also smooth journey will be there. But thing is that there is some differences there, but the service conditions are there between the cancer centers and the medical salary is almost same. But in coming to the private setup, we have to negotiate it initially itself. And after joining that, it's very difficult to change the terms and conditions. We should be very clear. But in the so-called 25 cancer centers, it's all managed by the health service oncologist. There are many people qualified even working outside the centers. So if you want to go to that service, you have to join the health service.
Then there are fellowships. Fellowships can be looked up at one way of improving academic skills or just a CV boost to get placed in a corporate setup. So Dr. Shamir, actually, how do you look at it? What's the exact takeaway from the fellowships?
I would like to do a bit of promotion here too, that we at the MVR-CCR, we have our own fellowship running now, and we have many candidates who have finished that. I have spoken to them. Fellowship is mainly aimed at, you might know about all these things, you have done all these things, if you have worked at a good center, you have done precision radiotherapy and things, but getting a leadership role in this kind of technologies is what is important, and many centers are looking at people who have trained further after your MD. Your MD is just a gateway, and people are looking at fellowships, whether you have done training in particle beam therapies and newer therapies, so that in the future, they're looking at the future and they want people to head such programs there and run academic training programs there, and this definitely helps you put you in a better league compared to somebody who hasn't undergone these kind of trainings, and makes you more confident and gives you the opportunity to dedicate that time to working in trials. that are looking at more and more newer techniques in delivering these kind of radiation therapies. So I think it's definitely a good step for somebody who is fresh, not a bad step for somebody who isn't that fresh as well and who's working in a center and wants to move on to other centers with such kind of technology. It's not a bad idea at all, because like you said, in the beginning 7 to 8 years is when you can do everything, and then personal compulsions force you to settle down somewhere. So that's the best time in which to consider getting into this.
How should they choose the fellowships? Should it be about the technique? Should it be about the subsite? Should it be about the institute?
Most fellowships are not site based, most of them are based on high precision. Do you have a fellowship running in your center, sir?
No, I
Okay. In the north, we have two now in Malabar. Okay. We have one running in MVR, CCRI and MCC also. So that's not looking at site basically. It's every site delivering because it's coming in every site now. And I think we're looking at the future. We are looking at a future where patients we might not have the 6-week radiotherapy anymore. At some point in time in the future, we might be looking at 5 fractions, 10 fractions, 20 fractions. This might be what we are going towards in the future. There might be very little areas where you go until 5-6 weeks of treatment, and for that you need more and more trials coming in, and you need more people trained in these kind of technologies to deliver it with confidence. And that's the most important thing. When a patient comes to you, they don't know how many years of experience you have had in delivering these treatments. What they know is the way you speak and the confidence with which you speak about what you have done. Your experience shows there. And that is important, I think, for a patient to have confidence in somebody who is doing these techniques.
Good. So after the fellowship, sir, JVM sir, should they come back to a private setup or can they come back to an academic institute?
Fellow, I tell you, in fellowship, it's not an approved degree. That you have to understand. It's only training, whatever you call it. So it is not approved in any of the government promotional prospects. But in private sector, they may agree, that's all. But it doesn't have much value for that. But whatever you do, you have to study properly. Then you have to do and demonstrate it. Then only people will accept you. And
so starting a radiation oncology department is a very capital expenditure resource demanding thing. So it's not very easy to start a radiation oncology department on your own actually. So most of the centers are crowded around in tier 1 cities. Is there an opportunity in tier 2, tier 3 cities where centers are coming up, or there's a possibility to start new centers, sir?
yeah, definitely there is a possibility of new centers. If you've got money, you can start. Otherwise, you can go. You have a group like that and you can invest and start it. Or you can go with the hospitals, established hospitals. You can have a tie-up with that. That Karkinos principle is like that. Karkinos, they don't have any hospitals as such into Kerala. They are coming and they are giving know-how and they are starting treatment like that. Even now the PRS, and they are putting a linear accelerator true beam, then by the PRS, they will run the department.
Many of my young friends here are cherishing a UK dream. So how do we go about it, Dr. Shamir? I said, many of them are cherishing a UK dream. So how do we go about it? Is it the traditional FRCR PLAB pathway, or is the MTA, Medical Training Initiative pathway? For those who are in there are 2 major pathways. One is the MTA, where you don't have to clear the PLAB and FRCR. You can go for a training in UK. Just need to clear the IELTS stuff, and then there is the classical FRCR PLAB pathway, which gives you an entry into the UK system. So Dr. Shamir, please.
Well, I chose the latter route because it was easier. And the FRCR is a tough exam, and it challenges you in different ways to your traditional MD or DNB exam. And one difference, I decided to appear for the FRCR exams 12 years after I had finished my post-graduation. So I entered it on a bet that they told me that you can't pass it at this age. So I thought, why not go and prove it to myself? When I went, I was in a class full of youngsters, bright-eyed youngsters who had just passed or going to pass, who were planning a future in the UK. And one thing I found I had a slight advantage is because of my classical clinical oncology training. the radiation part, the physics part, they were all very good. But when it came to clinical oncology and pharmacology and the clinical applications of these things, that was where most people found it difficult, especially if your center does not have a clinical oncology training, it's pure radiation oncology training. And this route, I think, is much better because if you finish your FRCR, you will be offered jobs there. Once you go there, you have the CSER route to a consultant, or you have the CCT route. CCT route, you had to go again as a student and do a shortened training there. The CSER route was pretty difficult initially. Now it has been made much easier. Before, you had to publish an audit, you had to publish a research article, you have to show them your competency in at least 5 or 6 sites, which was difficult for somebody who's working there to get rotation in all sites. Because when you go and work there, you're considered a consultant. So you won't get to rotate through all sites freely, because that depends on whether there are people already working in that department or not. So now they have made it 2 sites, no audit, and you have to collect your reflections on MDT discussions and tough clinical cases. Basically, you just have to write down what you researched on it, and how do you want to treat it, what are your feelings about your treatment. This is pretty simple to do, and it takes around you got to collect around 850 pages of data, and if you submit this, CSER route in oncology has the highest amount of approvals. So you're more likely to get an approval if you're applying for a CSER route in oncology compared to any other. Surgical routes are very difficult. Compared to that, it's much more common because they have a demand, and they want more and more consultants to clear this.
Great. So that's about UK. Got few friends actually who moved to US, moved to Australia and New Zealand as well. In Australia and New Zealand, you can clear similar to FRCR, there is an FRNZR there to move to UK and, to Australia and New Zealand. And then to Canada, some of the Indian degrees are accepted there for a fellowship. For a permanent job, you need to have the USMLEs. In US anyways, you need the USMLEs. So can you give us a global perspective, like with Indian degree, where all in the world can you work?
Well, there is a limitation still. And the first place I went to work was Malaysia, where an Indian degree is accepted. But your promotion and your climb in your career might be impeded if you just have an Indian degree alone, because all of them have started doing FRCR clinical oncology now. So they will be favored over you. And Singapore also does accept to a certain degree, but you're not allowed to practice as a full consultant. And many Asian countries, Indonesia does, Thailand does not, because they only accept US degrees. So there are a lot of Asian countries which are still accepting, but I think it's time that we start looking beyond that.
Africa.
And get the qualification. Because you said Australia, if you do your FRCR oncology, you have a quicker pathway in where you have a supervised 12-month supervised. You can become a consultant in Australia too. So that depends, and it's based on the location where you apply to. Certain locations, it's very easy to get through. So that might be compatible with Australia, but not New Zealand.
Now the most asked question, how about a DM medical oncology, sir? DM medical oncology.
In Indian scenario, medical oncology is medical oncology is an independence for practice. That's the main thing. When compared to radiation oncology, you need a linear high cost is involved. That's the main problem with the radiation oncology. Otherwise, there is a deficiency of radiation oncologists and the treatment facilities in India. All along, that is there. So in Kerala also, further scope is there. Even I started with a single person. Now we have 6 consultants in radiation oncology, 3 consultants in medical oncology, and 3 consultants in hemato-oncology, and 2 nuclear medicine consultants are there. 10 consultants in the pathology department.
Okay, so Sarah has got some slides. Whatever we have discussed here, not just theory, there are people who have actually walked the path. Sarah would explain this now.
Okay. Next slide.
Yeah. Yeah.
The main, you already mentioned, 35 and 10 to 15 people are there coming every year from outside because the All India examination. When NEET is there, many people are doing outside also. Those who are doing outside may not come to Kerala. And last week also one boy did MBBS in Orissa, then PG in Delhi, then married a Haryana doctor and came to settle, they wanted an employment, he came to KIMS. His CV is very good. If he apply to any place, they will take him only, our students. Then other things you can, there's research also, another things you can do. Basic research and clinical embryology. These are the academic, so I already mentioned that. Then the Indian cancer scenario, India, now there is, US, there are only 2 million new cancer patients are there. With that 2 million new cancer patients, they are doing many trials. In India, almost 1.5 million cases are there. So research is not there in India actually. So there is an improvement in the research. And similarly, this data published by the India, it was present in the last ARO in Calcutta. Anybody was there? There was a deficiency of 2,241 teletherapy machines in India. And then they need 4,034 radiation oncologists and 2,241 radiation physicists to adequately man the Indian scenario. Do you know him? He is Ravi Kannan, the Professor Padmasri Ravi Kannan, who got the Maxey Award. He was a professor in surgical oncology in Adyar Cancer Center. Then he moved to a small hospital, Kachar Cancer Hospital and Research Center. Now he has improved it. Similarly, another thing is that we need good mentorship. Professor Krishnan Nair, Professor B.D. Gupta and Dr. Krishnamurthy. Professor Krishnan Nair used to send many people to all over, almost all the staff in RCC were sent abroad for training, and even medical colleges, also people, nursing professors, all were sent for training. And B.D. Gupta used to see, Josh Tom is here, B.D. Gupta used to see that his students are placed in a respectable places. Then you can go near the Maranguti barrier is here, then Ben Rom, there is Masliva. They are, from the scratch, they have done a good work to establish a good setup. And meanwhile, you have to see the entrepreneurs also. So, Dr. Saudullah, when I moved to KIMS, there was nothing. Within a year, Bangar was ready and Ministry. I joined in November 1st. And next November, December, I took the first patient in the machine. Then the other, Diva Joseph, she came to KIMS for an interview. I couldn't take her. She moved to Nizam Cancer Institute. And then she moved to Rishikesh. Now she is the head of the department there. Similarly, Sham also. Okay. So these are the people who have gone to abroad also. Yesterday Charian was there. Ajit, you abroad also you can have a academic post or you can go for a non-academic post. So Rama is doing, she is trekking and she is doing very happy there in non-academic post in UK. Next. Okay. Fine.
So these are the conventional pathways. There are some unconventional pathways as well. When I say unconventional, it doesn't mean that somebody has not walked the path. It's a road less traveled actually. There is preventive oncology and palliative care. You can walk that path. Then I have friends who have done MBA after MD radiation oncology. One of my very good friends actually, she did MD radiation oncology, moved to the US for some familial reasons. Then she did an MBA from there, from one of the top universities, and now she's heading a startup in the product side. Then there is, you can do MHA, hospital administration, go for operations, quality, there is a severe dearth there. Then the entrepreneurship pathway, you can start radiation centers on your own. Then there are various other services which you can provide actually. You can take contracts, employ other radiation oncologists. So these are the paths less traveled, but these are not just theoretical. There are people who have walked that way. So what we try to intend here is not just to scare you. We just want to tell you that there are enough opportunities for everyone. You just don't have to be adamant that I will work only near home. Take whatever opportunities that comes your way, grab it with all your heart. The future is really bright. For one last question to conclude the session actually. So how do you see the future of the specialty, sir? Is it Dr. Shamir actually, what will be the one thing you learned from UK and you want to implement it here?
Well, we are, getting digitally more complicated and complex. Like sir said, it's become very expensive to set up a center compared to many years back. And we are looking more towards an era where artificial intelligence is going to come in our job and kind of help us and kind of reduce the amount of oncologists that might be required in a center. I'm sure that some of you are familiar with AI contouring. And I was working with MVision, and they were looking at more and more radiation oncologists to join their group so that even GTV, CTV contouring could be done by AI. And you just need to, modify the volumes. And that would greatly reduce the time that an oncologist spends on doing actual contouring. That is one of the shocks that I got after coming back here was, we were still doing a lot of organ at risk contouring by ourselves. And even the AI that is being used is not that good, because to modify that, you take almost as much time as you do an actual OAR. And so this work is being done by AI now, and AI is also working in helping patients understand the treatment better, reduce amount of time you need to explain a treatment to a patient, explain the side effects to a patient. They were looking at a future where every patient who is registered with the oncology department gets an ID, and in that ID their scans are all in 3D, explaining to them what kind of radiation would they be getting and all this, and then they come to you. They're already pre-armed with all the information. So this is going to be something that actually helps us do more, see more patients with a better result. And other thing is outsourcing of radiation. Radiology, as you know, is a highly outsourced job now. And this could come into radiation oncology at one point. All it requires is a machine that is in tune with your TPS. And you have video appointments now. And a radiation oncologist can very much sit in Kannur and see a patient in Australia or UK and do the planning, send it back to them. And for them, it's much more cheaper than actually hiring a team to go there and work with them. And so this is kind of like, where I see where AI would be doing a lot of our jobs. You're going to see more and more, like in the UK, the dosimetrists are radiotherapists who are trained at contouring and even doing dosimetry. They take a lot of the job of the physicists. They do a lot of our job as well. So it gives us a lot of time to practice, to increase our practice. And that's why we get to do a lot of chemotherapy more than radiation oncology there. And so that is another direction where your job might see some eating happening in the future. I know that we don't have a dosimetrist training, but I think we should have is radiation oncology nursing training.
Okay. If the time is over, so if there are any questions from the audience, please.
Hi, I would like to share my journey of 8 years post MD. Because there are a lot of majority are women oncologists here, I think we need to address many issues we face as women, meeting family life, rearing as a parent, looking into all those aspects. Life is not just work; it's a mix of all. So we face a lot of roles. We do a lot of roles and responsibilities. So there will be time when we need to take up a part-time job, or sometimes lay back a little. So I would just share my journey of last 8 years. So in case if people would like to understand that difficulties we face and the issues we face at life. I completed my MD from RCC and did few months of SRship there. There was a time when I thought I will venture into. So it is about not settling down and always be willing to keep learning and try new things. So I did a few months of SRship at RCC and continued my SRship at medical college. So if there is a point where you cannot continue SRship at some place, you can complete that 1 year or 2 years at another institute as well. So doing 1 year of SRship helps because you can apply for the PSC. Minimum, right now it is not it's not going to be mandatory, but the previous PSC mandates that you have 1 year SRship. So either you can do it as a voluntary SRship. As of now, it's mandatory, and new rule has come that when you do 4 years in health service, that also that's going to be implemented. I heard that if you do 4 years in health service, that even equates to 1 year SRship to apply for PSC. They're working on it now. So either you can do a SRship or voluntary SRship. As of now, it is mandatory. If you would continue that way, you can get into the academic centers like JIPMER or AIMS, where the SRship is mandatory. You can keep on switching. After that, I tried out as an associate clinical oncologist at Marsleva Pala. There again, I worked with medical oncologist Dr. Ronnie Benson. I was just trying out different things and which suits me and according to my passion and my interest. I had a time when my baby was small. I need COVID time, pandemic, when I had to stay back at home. So there in SME Gandhinagar, they were doing a BSc MRT course there. So that is a 4-year course, and they require radiotherapy, radiation oncologist as a post to teach these BSc students. Second year and third year is almost as same as the PG course. So I did from 20 to 22. Along with the SRship, I was also taking 2 hours of classes for them. Initially in 2020 and 21 and 22, I did online classes. So I was able to club it along with the senior residency. There was a point when I wasn't able to do both. So I needed more time at home and manage many other things. So I did only the academic session for about 8 months. So even they pay you a minimum scale. So always don't look at the payment and worry about the future. You can keep trying different stuff. Either you can try out the palliative care or palliative centers. You can do an essential palliative care 6 weeks or on-site workshops with Pallium India or CCPM or wherever. So you can keep trying different stuff. Go into teaching side or go into academic institutes or then try at academic centers. So if you have lost touch with radiotherapy planning, you can ask for voluntary observership at many of the private centers. So after I took that break, I needed to, in my mind, I always needed to work with SBRT. So then I asked Jospol sir at Rajagiri whether I can come and see the planning, and so he gave me some few days observership there. So you keep maintaining contacts and have a social networking, coming to CMEs. Don't back out after your MD life if you're not able to keep in touch with the radiation planning and radiation treatment. Still keep in touch, have connections so that you can, if you lose touch or go to health service, when you want to come back again to radiotherapy, you can go and do these observerships, voluntary observerships. Now I'm at present working at corporate hospital, KIMS as a specialist there. So I think we needn't settle down. We can keep trying. You can do these online or part-time jobs. There are clinical research officers. You can work as clinical research officers at a very good pay with pharmaceuticals also. That also can be clubbed with the clinical work, or you can do mix and match and try your interests. So initial 5 to 8 years, you can keep trying, and by the time you are reaching around 8 to 10 years, you will have these opportunities opening up. You can take an FRCR, you can go abroad, you can keep trying,
Thank you, Dr. Nasreen. That is a wonderful perspective. She's a true fighter, true winner. Thanks, Nasreen. And that's all. Thank you.
I thank all the speakers for a clear and practical overview of professional opportunities and career navigation in radiation oncology. May I now request Dr. Joeston sir to hand over a token of our appreciation to all the speakers. Thank you, everyone. Now for our next session, from employment pathways, we now move to an equally important subject, the quality and evolution of oncology training. We have a trainee perspective and a faculty perspective on this. The session will be chaired by Dr. Ajit Kumar VR, Professor in Radiation Oncology, Government Medical College, Alappuzha, and by Dr. Madhu CS, President-elect of AROI. I hope Dr. Madhu will join us in a few minutes. To talk on the trainee perspective, I invite Dr. Anjana Chandran, Senior Resident at Government Medical College, Thrissur.
Dear Chairperson, senior faculties and my dear fellow colleagues, good morning to you all. I am Anjana Chandran, Senior Resident, Department of Radiation Oncology, Government Medical College, Thrissur. Today I am interested to have a talk on improving oncology training, a trainee's perspective. As trainees, we are learners today and future custodians of oncology tomorrow. So the better training we receive today, better will be the patient care we provide tomorrow. So that takes me to the topic, why this topic matters. India is facing a rapid rise in cancer burden with increased life expectancy and increased diagnostics. So along with this, there is rapid evolution in radiation technology too, with IMRT, IGRT, VMAT, SBRT, and adaptive radiotherapy becoming a routine. So there is also increasing complexity of multidisciplinary care with more integration of technology. So training, as I have already told you, training quality today determines the patient care tomorrow. So a trainee's perspective is very essential for a meaningful reform. Before moving on to anything, I would like to acknowledge our strengths. We do have a high patient volume and diverse case exposure with strong clinical decision-making training, dedicated faculty mentorship, early exposure to treatment planning and contouring with real-world experience. These are our strengths, and this relays a very strong foundation for shaping a better oncologist, for a competent, better oncologist. In order to briefly say about how a typical day in the life of a radiation trainee, oncology trainee will be like, we start our day with the morning rounds where we see already admitted cases. We provide basic supportive care for them. We arrange multidisciplinary care for them. Then we move on to outpatient clinics where we discuss about further treatment plans, take informed consents, then plan about the further investigations. We spend most of our time by contouring and treatment planning, which also demands knowing about precision and anatomical knowledge. Then we are also responsible for ward care on treatment reviews, where we manage. We provide supportive care and also manage acute treatment-related toxicities. In between, we go for academic discussions and case discussions. And we are also responsible for emergency calls. So these are our strengths, and this shapes us into a better clinicians tomorrow. But this also states the facts. How important is it to maintain a structured academic frame, structured academics protected academic in between these busy schedules. So, heavy clinical workload often reduces protected academic hours. There is variability in structured academic schedules across institutions. There is limited formal training in newer technologies, and balancing thesis, exam pressure, and clinical duties together can be demanding for a trainee. So there is scope for more structured mentorship systems. There is variability in structured feedback mechanism. Protected research time is limited. Burnout and trainees often face with burnout and emotional stress. So understanding these problems will help us to tackle it more constructively. So, a structured academic framework with protected weekly academic hours, case-based learning discussions, regular contouring review sessions, multidisciplinary tumor board participation, standardized departmental teaching schedules will all help us to improve our training better. So, a structure will always bring consistency, and consistency can lead to competency. So, a clearly defined procedural competence should be the basis of our learning, and skill progression should always be milestone based. So, a trainee should start as an observer, then move on to assisting the cases before he is ready to do it independently. So, this will help the trainee to gradually develop the skill he requires without much stress. And there should be objective workplace-based assessment with OSCEs or mini clinical examination exercises. Trainees should not be prepared only for academics and for exams, but in order to communicate properly. As oncologists, we are dealing with end-of-life care. All doctors need communication skills, but we should practice it more because breaking a bad news, taking informed consent, all are very important and essential. And we should have training in that also along with our academic trainings. So there should be structured brachytherapy training, and simulation supported skill workshops should be there. This will prepare trainees better in order to, before we practice independently in a more better, safe environment. Research should be a part of our learning. It should not be seen as an additional burden. So for this, there should be dedicated research time and good institutional statistical support. There should be structured research mentorship program, and there should be encouragement for publication and multi-institutional collaboration. I feel that when a trainee start to ask questions and do investigate, they will grow beyond clinical competence. We are really lucky to have associations like ROI, VIROF, which has significantly advanced radiation oncology education in India, with regular CMEs and national state conferences, which provide valuable academic exposure. But there is always scope to increase dedicated trainee-focused CME programs and encourage structured training sections with major conferences. We can expand use of online platforms for wider accessibility. A hybrid academic models will ensure maximum participation. If a faculty mentor is assigned for each trainee, they will increase the continuous guidance, and there should be structured feedback sessions, career guidance discussions, which will clear the pathway for a trainee. There should be open discussions on trainees' well-being and burnout, which will foster a supportive and collaborative training environment. So, training training should also happen individually. It is not always an institutional responsibility. So we trainees should actively engage in academic and multidisciplinary forums with continuous self-learning in evolving technologies. There should be responsible logbook maintenance, and we should seek constructive feedback. We should support our peer and uphold our professionalism. So together let's envision a uniform competency-based training across the institution, which is technology-integrated, simulation-supported education with strong research and mentorship ecosystem and collaborative academic culture. So, I would like to conclude by stating that oncology is rapidly evolving and training must also evolve alongside these technology, and structured mentorship improves competency and confidence. So a trainee voice combined with faculty mentorship is very vital in shaping the future of oncology training. As a trainee, I have faced the strengths and challenges of the system. I'm not standing here to point out the gaps, but in order to further strengthen a system which is already very strong. And I also know that many of the things I have discussed is already being implemented in many of our institutions. I just want to state the importance of sticking and adhering to these structured system and the importance in making sure it is equally implemented in all the teaching institutions in order to ensure a uniform excellence in oncology training. So, with this, my dear fellow trainees, train better today to treat better tomorrow. And I would like to take this opportunity to thank associations like ROE, VIROF, and all the senior faculties who have put their heart and effort in teaching and improving our academics. And I also thanks ROE for giving me this opportunity to speak on behalf of trainees. Thank you.
Thank you, Dr. Anjana. Now for the faculty perspectives, I request Dr. Francis V. James and Dr. K.L. Jayakumar to speak on the faculty perspective.
Good morning. It's a very important topic. Dr. Anjana had already spoke too much on that, and I think almost everything is clear after her presentation. And one thing which our radiation oncologist trainee face initially is this is not included in your curriculum, as I told yesterday. So as and when a fresh graduate comes out of their MBBS and join for MD in radiation oncology, they do not have any idea how we manage about radiation, the physics part, and they are not seeing any of the cancer patients till they finish their MBBS course, because all other specialties like medicine, surgery, everything has already been taught and they have an idea. Whereas our radiation oncology students do not have any ideas. So during the first 3-4 months, they will be just observing what we are doing, what their professors are doing. That is what they do. And the initial period, initial part of their first 3-4 months, many of them just wanted, I have joined this specialty, I don't know how I will. And so that part will be over another 3 to 4 months time. Then they started enjoying their specialty. After seeing one thing is, when they join, they will think that all the cancer patients are not going to be with us for another 3-4 months, Why unnecessarily treat these patients? Then after you come across so many patients who are treated, trained and cured, then they will start loving this specialty. That is the initial part which I have found. And one more thing I just wanted to emphasize before Francis take over is that now many of these students, students, they are given a case, for example, say a breast or lung case. What I found in the recent years is that they will just find out first the diagnosis. Then they will see the MRI or CT. and the final pathology, and they will just go and present, Any communication, as Anjana has mentioned, you are the first person to communicate with the patient to, to break the bad, this thing. And also you have to take detailed history and detailed clinical exam. That's most important as far as a trainee is concerned, Then they have to see the pathology. Even the pathology report, what I would find is, they don't look at the details of the pathology, the microscopy or the gross pathology, many don't, only the final diagnosis. That is something which has to be changed as a trainee. Further I will talk, let Francis speak on this. And it will be an interactive session, all the professors are here, you can also join.
I don't think we need to this thing need to be restricted to two of us. Everyone can chip in and say their comments. What is obvious these days is lack of clinical examination by trainees. Everything is in MCQ format. NEET is MCQ, NEET PG is MCQ. So you only think about a situation where you think about theoretical perspective. When you examine, most of the cases are seen, you put on all the investigation results, everything is in the case sheet, but the exam bit is that is vacant. So there are few situations where the clinical examination will make huge effect. A patient with thoracic or abdominal disease comes with a CT scan, and the trainee looks at that there is a lung lesion which may be operable, there may be an abdominal disease which is operable. If they put their hand on the neck, there may be a supraclavicular node, and then there is no issue of surgery at all. You don't have to give a reference, and that ends there. But that bit of clinical examination is not done by many trainees now. I think Jayaprakash Madhan sir is one of the proponents of supraclavicular fossa. Everyone knows that he puts the finger first in the neck before examining anyone, because that makes a huge difference for any patient with thoracic or abdominal malignancy. So a supraclavicular fossa examination is a must for any trainee in oncology. I'll tell few situations where a clinical examination will make huge effect. On supraclavicular fossa examination, vaginal examination, for CA cervix or endometrium, vaginal examination will show many times an additional nodule in the vagina, which may not be picked up by any investigation. There will be, apart from the primary lesion, there can be a deposit in the lower vaginal wall, anterior vaginal wall, or some other skip deposit, which is not in any imaging, but you will only feel by your finger. So that will make a difference. Sorry. Another thing is pouch of Douglas deposit. That also you have to learn how it feels like, and if you learn for some time, then you immediately pick it up, then that makes the life of the patient different. Then it is no more operable, and all about it. And the other is a situation, clinical situation, where patient has a pneumothorax and it seeps into the neck. You only have to put your hand on the neck, immediately you know that this is pneumothorax coming to the neck. But I'm sure a lot of trainees haven't ever felt it and cannot recognize it. Am I not? So once you examine it, you remember for your entire life. So there are so many clinical things which you find out by clinical examination, not by investigation. It may miss on an X-ray to have a pneumothorax, but this thing you cannot miss if you have examined one. So all these clinical findings are very relevant. So people have to be aware of the value of clinical examination. And the second component I want to say is documentation. These days the documentation appears to be poorer and poorer, because the patient comes to the clinic many times, so you have to put a date and time and record it, and when they come for a next time, you have to record it. This will become very important, especially when medico-legal issues come in the future, which is quite likely to happen, because there is overpopulation of doctors now. So this way to survive is to complain about someone. So there will be more and more problem in the future. So we have to be very aware of documentation. And another thing is that whoever is asked question, they have no doubt how the patient is treated because they remember the NCCN recommendation. They just say, this is the treatment. Because they never put that recommendation on a patient perspective. Because a patient recommendation may be something which is applicable to people with only performance status 1. He may be performance status 3 on wheelchair. This doesn't apply to him. You can have a curable illness in an incurable patient. So that is something very important. One can get a Hodgkin lymphoma at the age of 85 and you cannot cure him by the standard recommendation. You will have to modulate, you might only palliative, then he might live sufficient period of time. So a curative illness can be there for a patient who cannot be given the full dose of treatment. So there will be a lot of modification for treatment. So those perspectives should come into your mind so that you recommend a treatment for the patient in front of you rather than the recommendation in the textbook. But somehow people have too much faith in the books and recommendations and flow chart rather than the work you do every day. There is no connect between the two. That's very important for the future. Then regarding teaching, I think every department has journal club, symposium, clinical case discussion. The journal club, most of the time what happens is that they read out the journal and they read the corresponding reference journal. But generally people doesn't criticize how it is done. They don't criticize on statistics. They don't critically evaluate the quality of the paper, which is the most important thing. I think people need to attend more epidemiology discussions and statistical classes, which I think is coming down. And then about planning and contouring, I think most of the contouring will go away in another 5 years' time. Artificial stuff will come in and all the so-called, the trainees think my job is contouring, but the contouring will go away. So you have to be prepared for that. You need only editing GTVs and CTV. All the other things will be done by. So that's the future. I have no doubt about it. And brachytherapy, there are many centers without brachytherapy and trainees come out without doing any brachy, which is actually sad. During their training time, there should be some good exposure. I think 2 months they have to be in a unit where there is brachytherapy so that first 2-3 weeks they see, then they do some minor ones and then they go to intrauterine and intracavitary. So that's, I think they will need something like 6 to 8 weeks at least. Just 1 week, I've seen people coming for 2 days and 3 days. That's not enough. And they have to go apply it. And another thing is that they think their job is applying. So in the theater, they put in the tube and they're happy I did. They might give coffee to the staff around and then they walk out as if they succeeded. They don't know whether they succeeded or not because they don't look at the CT film, CT sim picture. They don't look at the planning. And one best way during exam to check whether they have followed it is to ask what are the 3 colored lines in the computer after you do brachytherapy. That's a simple question I ask. And then you know whether that person was in front of the computer. And what do you do if the D2cc dose to the rectum is more than, so what will you do? So then you know whether they were around the computer and planning system. That's the simplest way. But those things you have to learn over a few weeks rather than 2 or 3 day posting. I know some people go just to, they say really, I want to see brachytherapy. That's not very useful. And then all PG courses are not taught courses. They are all self-learning process. So you don't expect them to teach in didactic lectures and theory. So those things you have to slowly read. And interestingly, what I see is just before the exam, they take off 1 month and they learn everything in a very speedy way. And during the 3rd week, they start thinking that this was what I was doing for the last 3 years. And then they go for the exam, write it out, appear for the exam, pass, and everything vapor from the brain. So then start with clean slate. Many people have described it that way. So that's very common. And those are few bits I'm telling. But
to add on this, one more thing which I have found is, you have to treat the patient as a whole. As Francis sir said, clinical exam, starting with the clinical examination, then only you have to look at the other investigations pattern. One more thing which I have found recently is that whatever questions we ask during the rounds or during the presentation, you know, what is the stage and what is this thing, or immediately they will put their mobile and everything is written there. They look at that, then it's so and so. That is something which is a new trend which is coming up. I don't think it's good, you know. So they look at the what is the treatment you are suggesting, you know. They don't think about that. If you ask, you know, say T3, T2, N1 disease, CA breast triple negative, what is the treatment? Immediately thinking about that, they will look at the computer, the two other PGs sitting next to me will do that, and they will tell that. So that will never improve your future actually. That is something which I have noticed in the recent years, you know. What is Madhu sir's? You also a teacher?
Actually, regarding, I would like to say of myself, you know, I learned the maximum after retiring from the medical education services as a professor. You know, during my period of service, I had undergone training in UK, USA, every other places. But maximum I have learned after retirement. So it is a continuous process. And the best teacher, if you ask me, is our own patients. You have to learn from patients. Every day I am learning so many new things and approaches from patients. Even some of the things which we suggest to the patients, they will be modifying, and when they have modified and when they tell what they have done, then we will be getting new ideas. So that is one thing. Then with regard to the training program, one of the things which I urge every radiation oncology trainee to undergo is basic endoscopic assessment. Indirect laryngoscopy, definitely one has to do, but apart from that, fiber optic scopy. If I have seen in UK and USA, in the radiation oncology OPD, they do this scopy evaluation. And that is very much needed for us to do better planning of radiation and better follow-up and better assessment of response to treatment, etc. Then coming to the breaking the bad news. I am one person who has undergone palliative care training, not only in India but also abroad. So there also many of these people who are involved in palliative care, they will be talking about breaking the bad news. But they are not the right people to break the bad news. They cannot, it should not be allowed at all, because their knowledge about these things, oncology, is very meager. So palliative care cannot be practiced without knowing oncology, and oncology cannot be practiced without knowing palliative care. So if a proper breaking of the bad news is to be done, it has to be by the senior most person, and the trainee should listen to it, and unless and until they have a good knowledge about the overall management of and the outcome of treatment, etc., they may not be able to do a proper breaking of the bad news. So this is also something which every trainee has to keep in mind. And the overload of work, everything, I still remember the days when myself and Professor Jostrom, we were the two people along with the professor who used to leave by 12 o'clock, but we used to do care of so many patients in Government Medical College, Kottayam. So that was so still it was possible for us to do meticulous examination of cases, follow-up, etc., as Professor Francis rightly pointed out. Unless we do a speculum examination and a very good clinical examination, we will be missing many things. I still remember some of the basic things which I have been told during my Madras days by Professor Munusamy and Jagadishan. So this is also very, very important in a busy OP. Sometimes there may be problems in detailed examination, etc. But somehow make it a point that even if you are hungry and even if you have not taken the lunch in time, you should find time to do justice by proper examination of the patients and proper recording, etc. And the best way to learn is retrospective evaluation of consecutive cases, what has happened. So there is huge data in the regional cancer center, for example. But during my period in RCC, I have learned a lot by retrospective evaluation. And that is something which, there may be problems with the institutional review board, etc. But certainly for your learning, at least, people have to go through the case sheets and see what has happened. You should make a phone call. You should send the follow-up letters. That is the best way to learn. I know that we can discuss a lot about many things.
And what is Dr. Tom's comment on this, please?
I'll just add one or two points regarding the training program. One thing which I find now, see, a patient, Judith also knows, we are in a private setup. A patient comes to oncology department, patient has a pleural effusion. Who is going to tap the pleural fluid? Patient is referred to the pulmonologist. Pulmonologist now refers the patient to the interventional radiologist. It has come to that. You should see, there was a strike by the house surgeons few years back in medical colleges saying that venesection is not our job, that is nurse's job. I will not take blood. Do you know how to make a venipuncture? You should learn all skills. I have done pleural aspiration at home of patients. I have done ascites tapping hundreds of times in many patients' houses. It's simple. Last day, my cousin is admitted in a hospital now. He went to a hospital for ascitic fluid aspiration. 2 days, they put in the ICU and aspirated 55,000 rupees. That was the only charge they charged.
I still remember Jostom used to make me do the not biopsies, We used to do it in our OPs.
We used to do biopsies in our OPD, oral cavity biopsy, all those things we used to do. So, learn maximum. Bone marrow aspiration, the IV infusions, chemotherapy also I have given at home. Understood? All these things, see, you may require that sometimes. So, learn all skills.
Thank you.
Those
Tom.
are not below your dignity.
Thank you. And
actually, this is something which is very painful for us to know, because in a private setting, just like what Professor Jostom said, a biopsy will be costing 5,000, 6,000 rupees. But these things were not.
Thank you. Everybody has told many things to you. When private, there's a difference in a private setup and a government setup. Now, when I started in KIMS, I used to do all these things, starting from bone marrow, everything. I was alone at that time. And now it has gone to just some institute to interventional radiology, intensive care, and it may take 2 days to get it done. So I tell them, if you have got ascites, go to nearby hospital and tap it. That's the best option, you can do it. Similarly, you have to learn all the skills. And regarding the training also, you have to observe what others are doing and you criticize. If we are doing something wrong, you tell us what is the problem doing other way around. That's the one thing. Many people, they don't ask. Even the multidisciplinary board also, all the trainers, they'll keep quiet. I don't know why. All people in our training board, multidisciplinary board, they don't ask any questions. I don't know why. Your clinics are also like that?
And finally, before winding up, one more thing which I just added is you have to have a good communication between your colleagues, your mentors, and your physicist, the radiographers, and all those stuffs. You have to have a good personal relationship. That's also very important for your future. Thank you so much for giving us the opportunity.
The radiographers and physicists also will be able to teach you a lot. You have to learn from everybody, even from the nursing assistant, you will have to learn.
Thank you so much, sir.
Thank the chairpersons for a balanced and constructive discussion. I request the chairpersons to hand over a token of appreciation to our speakers. I request the chairpersons to continue on the dais for our next session. The next session addresses a deeply human aspect of oncology practice, communication with patients and breaking bad news. The session will be delivered by Dr. Rari Rahman, Consultant, Department of Palliative Medicine, ICRA International Hospital, Calicut. Over to you, ma'am.
Thank you. So how to do this? Good morning, everyone. I'm truly humbled to be here as a faculty, and I express my sincere gratitude towards Francis sir and the organizing committee of Kerala Aroicon. So my assigned topic is communication with patients and breaking bad news. We doctors do communicate with patients on a daily basis, but sometimes we feel some difficulty in the process. So I'll be covering the basics of the session, and I will try to, I hope that everyone will benefit at some level within 30 minutes. So let's start. So communication is a two-way process, it's a two-way process by which information is shared between two or more people. And it is a complex process, and if it is not done with clarity, the information that we are trying to communicate may get misunderstood. So it includes, the process includes a sender, a receiver, a message, and the medium. Here I am the sender, you people are the receiver. The message is about the session, and the medium is air. Now, communication has got three components: the verbal component, non-verbal, and paraverbal. Verbal component include the content of the message, that is the words we are using. Non-verbal component include the posture, the gestures, the facial expression, touch, eye-to-eye contact, the spatial distance, etc. And paraverbal component include the tone, the pitch, the volume of our voice, and the pace of our voice. And it is said that more than 70% of our communication occurs by means of non-verbal and paraverbal component. So our body speaks more than our words. Now, aims of a good doctor-patient communication, obviously it will help to enhance the mutual relationship between the two parties. It improves the trust in the patient. It helps them to have a realistic hope, allow the patient to adjust to the treatment status, disease status, helps them to reduce their uncertainties, help them to have a proper guidance, and help them to have better compliance and adherence to the treatment, and also it increases the personal satisfaction at both levels, like doctors and patients. Now let's see some of the consequences of poor communication. It may cause emotional distress for both patient and doctor. There may be conflicts between patient and doctor because of poor communication. Lack of cooperation and poor adherence may occur due to poor communication. Poor symptom control occurs due to poor communication. Studies have shown that, and even medico-legal issues may occur. So let's see some of the barriers for effective communication. It can be divided under two headings, that is the healthcare professional blood barriers and patient-led barriers, which can be again explained under two, that is fears and beliefs. So coming to the fear of a healthcare professional which act as a barrier, fear of upsetting the patient, fear of dealing with patient's emotional response, fear of saying the wrong thing and getting into trouble, and fear of asking difficult questions like, why me? Why this happened to me? Now, some of the doctors believe that emotional problems are inevitable in patients with cancer and we can't do anything. And even some people believe that it is not my role to explain all the things. The senior most person should communicate everything. Obviously, lack of training is a barrier, especially how to handle specific communication issues like breaking bad news and difficult questions. And language and dialect is also a barrier. Coming to patient-led barriers, patients usually disclose about 40% of their concerns, and the patients who are more stressed or anxious disclose the least. The beliefs the patients have which act as a barrier are, doctors are too busy to hear my concerns, doctors are only concerned with certain part of care like treatment and disease diagnosis. Conveying my concerns may increase the burden for the doctors, and some patients may think that their worries are insignificant. And their fear of losing their control in front of strangers like doctors and nurses, and some people even fear of having their worst fears confirmed. So let us have a look at the slide, and sometimes we behave like this. So, coming to effective communication. What is effective communication? We have to understand that history of a patient is his story or her story. So we have to listen to the story, we have to listen it actively. So how can we listen actively? These are some of the strategies that helps us to listen actively. Firstly, make the patient comfortable, maintain a good eye-to-eye contact, show the patient that you are interested in what they are saying by moving forward or leaning forward towards the patient rather than leaning against the back chair of the backrest of your chair. Then use non-verbal gestures like head nodding, saying okay, like okay is a word, but saying that phrases in sounds in between. And mannerisms like holding the hands or sometimes even patting on the shoulder if socially acceptable and if needed, and try to interrupt minimally. Then always paraphrase or reflect back towards the patients what they have said. Check their feelings in between. If they are being too emotional, like ask them, are you comfortable in moving forward? And while concluding the session, always ask the patients whether they have anything else to say or any queries that to be addressed. And finally, you should summarize the whole communication, the whole session, and always be empathetic and give realistic hope only. Now, active listening, it along with the verbal component, it also gives us idea about patient's motive, needs, and attitudes, and it also helps us to understand the burden of the disease that is causing difficulty in the quality of life of patient. So, Coming to breaking bad news, which is the most important part of the session. Bad news is always a bad news. We have to admit it. And no one likes breaking bad news. It is always a learned skill. So this slide shows that the stress level of the patient and the doctor during the appointment while breaking a bad news. The doctor's stress level peaks in between the session, and the patient's stress level peaks just after the session. So what is bad news? Bad news is any information that adversely or seriously affects an individual's view on his or her future. In an oncology setting, these are some of the areas we have to break bad news, or some of the bad news, that is diagnosis of a cancer, spread of the disease, disease recurrence, disease progression, complications of the treatment, transition of phase of care from curative to palliative, and end of life care. Now, why it is important to break bad news? As I have already said, for a better adjustment for the patient with the disease status, for proper guidance and better compliance, for better acceptance and trust. And even though they are patients, they all are human beings. They have their own issues, their own wishes and all. For getting time and to plan their future, we have to we have to tell them the truth in a better way. So breaking bad news should always start with asking questions or asking statements. It should be done at the patient's pace, and even though there are some guidelines for this, we have to understand that a single guideline is not absolute, and it should be always done according to patient's need. So this is one of the most followed guideline, that is a SPIKES protocol. SPIKES, as the name indicates, S stands for setting up the interview, P, patient perception, O, I, obtaining patient's invitation, K, knowledge and information sharing, E, addressing patient's emotion with empathy, and S, strategy and summary. So let's have a broader view. Like before breaking a bad news, you should always prepare yourself. Like familiarize with the patient's details, the medical records, the test results, the treatment plan, etc. If possible, try to mentally rehearse it with the likely questions and responses, and if needed, have another colleague or nurse. Now, prepare your setting, should maintain privacy, and try to put your mobile phone on silent mode. You should provide an uninterrupted time and undivided attention to the patient. You should be in a sitting position so that it gives the idea to the patient that you are not in a hurry, they can express freely. Now, be the first to greet the patient, and if socially acceptable, shake hands, and know the patient's name and address the patient by their name. Now, establish eye-to-eye contact and try to maintain it at regular intervals. Then allow the patient to choose their close relative or family member. Put the patient at ease. Some patients will be too nervous, so ask non-medical inquiry, like tell about your family or what's your job, something like that before starting the communication, breaking bad news. And if you have recently examined the patient, rather than communicating with the patient who is behind the curtain, allow them to get ready and be seated. Now, prepare your patient. Firstly, assess the patient's understanding regarding the condition. Ask the patient directly, like, what is your thought regarding the illness? What could be the test result? Why you have come here? Like that, ask the patient directly. It will give, the patient will respond, and it will give you idea regarding three things. They are, how much the patient is aware about the illness, how much patient would like to know, and is the patient ready to know. And never impose information, that some patients will be okay with knowing less. So don't impose them with more and more information. Now, providing information, firstly, invite the patient. Assess whether the patient is ready for breaking bad news, ready for the information. So ask the patient, are you okay in telling regarding the test reports or the disease status and all? Are you ready? Ask them. If they say yes, go on. So start from the using the vocabulary that patient has told about the illness, start from that, and avoid the medical terms to the minimum and, sorry, to the maximum, and use words like spread for metastasis and all. Avoid excessive bluntness and try to set the tone of the communication. We can say that like the report is not as good as we had expected. It sets a tone and it gives the patient a hint that the report is not, it is going to be bad. Now, always give the information. That is the main part of this, breaking the news in small chunks or warning shots. First, say a little bit about the whatever the disease or prognosis. Stop that. Try to figure out that patient has understand what you have said. Try to understand their response. If the patient is understanding, go forward. Now, in between, ask, would you like me to explain more? Are you okay? Are you comfortable? Like that. And if the prognosis is very poor, try to avoid phrases like nothing can be done for the patient. Rather, we can tell the patient or the family that till now the goal of care was curative, but we are trying to shift from curative to palliative or symptom care. Now, providing support. Obviously, patient will respond emotionally. These silence, crying, denial, anger, bargaining, acceptance, sadness, etc. are the responses that patients do. So, support the patients and express it empathetically by moving towards the patient, trying to hold the hands if socially acceptable, and allow the patient to express their emotions. And acknowledge the emotion. Say the word, if the patient is very angry or if the patient is very sad, say the word like I am understanding that you are very you are feeling very sad or you are very angry now. Say the words, acknowledge that, and when the patient is very silent, start the conversation with open-ended questions. Now, finally, provide a plan to the patient regarding the future, regarding treatment options, management, etc. Always summarize the whole process, the whole communication, to check whether the patient has understood and to check whether there is any misunderstandings. And we can also offer to meet and talk to other family members if not present. After the interview, record the whole detail of the interview, which include the terms that we have used, the options discussed, and the future plan. Ensure the other team members are also informed regarding the same. Provide a next review date and provide contact details for queries and clarifications. It is said that there is a saying that break bad news well and you will always be remembered. Break bad news badly and you will never be forgotten. So there are some statements which won't help us or patients. Try to avoid those. Some examples are: nothing can be done. I understand how you are feeling. It could be worse. We all die. Everyone has their own sufferings. Don't worry, everything will be all right. Try to avoid all these statements and never ever give a bad news over the phone. Now, breaking bad news is an emotional roller coaster for the doctor too. So take time, calm yourself before you see the next patient. Sometimes patient may ask difficult questions after this or in between. So there is a guideline. Always acknowledge their reaction, then paraphrase it to check that whether you have understood it clearly. Then explore the concerns behind that reaction. Sometimes patient may ask, how long I will live? Rather than giving the 5-year survival rate or the value, ask them what thought made you to ask that question. They may have some concerns. So explore the concerns, help the patient to make a decision, and please don't find solutions for the patient. If sometimes there may be questions with no answers, and remain silent and say we don't know. Now this is a case scenario, 40-year-old lady, Lata, who is married and having 2 children. Her husband is not that much supportive. She is in a case of CA breast with bone mets. She is on palliative intent oncological treatment. And once she comes to your OPD and says that, I am so worried, I can't sleep properly and pain on the back is still there. How you will respond? I want an answer. like how you will respond. Let me give you some options. In which manner will you try to respond? Sir.
We would like to know more about the pathology, the treatment which the patient has received, and everything. And then the clinical examination. And with all this, we can definitely break the bad news in the best possible way. The outcome of treatment, the bone metastasis in a breast cancer doesn't mean that the patient is going to die in 6 months or anything.
No. It doesn't mean that the patient is not going to die.
The point which I told earlier, you are a qualified oncologist, I agree. You are the right person. But there are lot of palliative medicine specialists. Your MD radiotherapy degree is not a feeder qualification for DM in palliative medicine. So such people, when they come out, how is it possible for them to do a good breaking of bad news? It's not possible. I have patients with bone metastasis from lung cancer living 12 years, more than that, many patients. So these things only somebody who has experience in dealing patients only can break the...
Yes, I agree to you, sir. Breaking bad news is not done, it shouldn't done by palliative care people, and it should be done by the people who are treating the patient, especially the oncologists or the other super specialty, nephrology, neurology, everywhere. So I agree to you fully, sir, and let me continue my presentation. Please. Yeah. What would be the response? Like, I hope everyone will choose the fourth one. Okay? Now, communication in a nutshell, it is best learned through experience. Identify your skills and refine them. Identify your shortcomings and try to overcome them. There is no fixed guideline, and it should always be patient-centered and context and cultural-oriented. Accept the limits and never ever assume. Thank you.
Thank you, Dr. Rari, for the excellent presentation. This talk is actually a continuation of the previous one. So what is important is good communication skills. Good communication skills with the patient will help you to smoothly convey the bad news. If you have good communication skills, you can have the entire rapport with the family and all, and can clearly break the bad news.
Actually, our outpatient departments and clinics are flooded with patients. But to be frank, if it is very important for people to have some exposure in countries like UK, USA, etc. And I have seen how they break the bad news. For example, one patient with carcinoma cervix and at the same time pleural effusion. The patient was seen by Professor Jocelyn. He said, your disease is incurable, but we will make you comfortable. The husband and wife were crying. He took his own handkerchief and wiped the tears, and then a cup of coffee was given, and then the social worker did the rest of the thing, and the patient was taken to home in the hospital conveyance. So such detailed and time-consuming breaking of the bad news is actually very much needed. And also, I can talk a lot about many of these end-of-life care, etc. But the time is not permitting. But it is an art, and then you have to learn it, and it can only be done by people who are in the field and who are. And at present, we are facing a lot of problems from these palliative medicine people who tell that when there is a brain metastasis, all that the patient requires is steroids or no treatment, or they will start, what is called, നമ്മുടെ പാലയിലൊക്കെ പറയും മരിപ്പിക്കുക. അത് ഇത് മാറണം. കാരണം ബ്രെയിൻ മെറ്റ്സ് ഉള്ള പേഷ്യൻസ് they are living 10, 12, 15 years. And even without radiation, many people are living. New targeted therapies have come. Everything has revolutionized. So these things have to be, I think it is high time for us to conduct an oncology course for palliative care professionals.
Ma'am, I have a question. What about high volume centers where we see around 50, 60 patients a day?
It's very difficult. It's very difficult.
How do we take the time to give this much? Like, how do we prioritize the patients?
The first visit is very important. Especially the first visit with your patient is very important. The words you have communicated to the patient will be always with the patient and their family. So be gentle with them. Take some time with the first visit. First visit, I mean that with the reports and diagnosis, when you are trying to explain the treatment protocol, the complications, everything. That visit is very important. We had a patient who was 15-year-old. He was diagnosed with synovial sarcoma. I guess I'm not sure whether it was the diagnosis. He was consulted by an oncologist. I don't know whether he's a pediatric or a radiation or a clinical or medical oncologist. The message the doctor conveyed to the patient party was he won't live for more than 6 months. So don't try for higher things. That was the message they have the doctor has conveyed. The patient took treatment from a well center and lived for about 1.5 years, and with treatment breaks in between. The condition improved. The patient went back to school and all. Everything came their life became lively. And later, obviously, the disease progressed and patient ended up in palliative medicine. But the father of the patient insisted for aggressive management, even though the pediatric oncologist suggested just to go for symptom care. The father suggested for ICU care, and the patient finally ended up in ventilator. But the main problem occurred at that time where we couldn't wean off from the ventilator. We can't extubate the patient because the family was not at all willing, because of the thing is that they don't trust doctors, because the doctor they have consulted first have said that he will live only for 6 months, but he has lived for 18 months. So we won't trust you, but we need help from you for the treatment. That's only. And finally, he died on the ventilator on day 15. So the first conversation with the patient is really important, and you should take time.
Actually, ഒരു common scenario എന്താണെന്ന് വെച്ച് കഴിഞ്ഞാൽ, when somebody is coming, children will be coming first, and then they will say, ചാച്ചനോട് പറയരുത്, അമ്മച്ചിയോട് പറയരുത് എന്ന് പറയും. How do you deal with such situations?
So that is collusion. That is disagreement between the family members or the patient and the family. Firstly, we have to try to understand why they are saying, what is the reason behind that statement. Don't tell to patient, don't tell to my mother or dad, and try to convince them that even if we are not telling the truth, even we are not telling the diagnosis, the disease is occurring in a patient. The patient will perceive the changes that is occurring to the patient, and finally, so may I continue?
The hospital rule is that without the consent of the patient, none of the details should be disclosed to the relatives or friends. That is a general rule.
You have asked the other thing, no sir?
No. I am telling you, the hospital rule, the general rule
yes.
is that
confidentiality is very important.
Without
Yes.
the consent of the patient,
yes,
the details should not be revealed to
other people.
The family.
Yes.
Even the family.
Yes.
So first you have to tell the patient.
Yes. That is a rule. But here we, it,
For a minor, that is not applicable.
For a minor.
For a minor, that is not applicable.
yes, yes,
Because parents are not
yes.
It is not a very simple solution, a simple thing. I have even come across our own students who explain to the patient that finally, when the patient is very fit and as healthy as me or Joe Tom, but the concerned doctor is telling that I have nothing more to offer you, everything is over, and the patient is in tears. This has happened in Caritas Hospital. I can tell you, your student and my student.
Thank you very much, Dr. Dari, for that presentation.
Thank you.
I request the chairpersons to hand over a token of appreciation to Dr. Dari. I request the chairpersons to continue for the next session as well. For our last session of the day, on administrative challenges in oncology, I invite Dr. Joe Storm, Senior Consultant, Radiation Oncology, Caritas Hospital, Kottayam.
Respected chairpersons, Dr. Madhu will remember the conference when the umpire told the last batsman is walking in, and I am the last batsman today. So my topic is administrative challenges in oncology. Okay. Having worked in a medical college, I am talking generally about the medical college setup. Usually, when we joined medical college, we joined as tutors. Later, the position was renamed as lecturer. I don't think that now the point of entry is assistant professor. And from assistant professor, you become, over a period of time, you become associate professor, then additional professor or professor. And Madhu and me took probably more than 20 years to become professor. And I was asking one of the junior colleagues here yesterday, he has taken, now he has been in service since I think 12 or 15 years, still assistant professor, but getting the salary of a professor because of the time-bound promotions, which is happening now. That is a good thing. So then from professor and HOD, you can become a principal or which is equivalent to the joint DME post, and finally the DME. That is your academic progression or career progression in medical college service. As you go up in the service, in the hierarchy, more and more challenges will crop up. When you are an assistant professor, you do not have much of administrative responsibility. At the time you become a unit head or a head of the department, you will have more of administrative challenges. You will be part of a crucial decision-making team when you are in administrative phase. So, as you climb up in your career, be prepared to take up more responsibility. That is number one. There are many doctors who are posted in health centers now in taluk hospitals, district hospitals and all. See, if you are happy with the position, you may be transferred, but there you may be the only person to take the responsibility, not like medical colleges and all, but wherever you are, if you are the responsible person, you should have a vision to develop your institute. You may be there or may not be there in future. Somebody else may be coming up. So you should definitely have a vision to develop the institution as a good comprehensive cancer center. That you can decide, the scale of development you can decide. Say you may think that you will, in future if I am here, I will bring in 2 LINACs here, I will have more radiation oncology colleagues with me, I will have other medical oncology team, I will have a surgical oncology team, I will have a palliative care, a comprehensive cancer center. If sufficient space is there or land is there, you can plan accordingly and you can give your vision or you can give a paper to the administration saying that, say, in future we should develop this thing. And development everybody likes. And in paper at least it will be there. And you can say that this land, probably we can develop this area as the cancer center. It is the usual procedure in a government setup that the PWD will find some land there. We will have this thing here. We will have this thing here. Now, this is earmarked for a future cancer center. So, you should have a vision like that. Let that be there in the paper. If somebody comes after you, there may be minor changes. But the basic vision of a comprehensive cancer center will stand. Second is participate in everything. Take active interest in departmental activities from the very start. Dr. Madhu said that when we were lecturers, we had a good professor who used to entrust us for the responsible jobs. And the first cobalt machine, which was purchased to the cancer care center in Kottayam Medical College, I think we sat together for, Madhu and me sat together for nearly 6 months to compile the, what is that called, specifications. Till that time, the cobalt machine specification was rotational telecobalt machine of 60 centimeter SSD. That was the specification, single line specification for cobalt in Kerala or in India. That was the specification. And even now, I have the draft prepared with me, the 6 months job. And ultimately, when we gave it, the companies shouted at us, who prepared this type of specification? We were very specific in many points, and they had not seen such a specification earlier. And so, when we got the chance to get involved, as junior assistant professors, we took the opportunity, and from then on, later when I came to Trichur, I wrote the specification, Madhu modified it and purchased the machine, cobalt machine here. So this gave us good opportunity. So grab any opportunity you get to be a part of the administration of decision making. Second is learn good things from your seniors. There are people, very shrewd people, like Madhu, a product from RCC Trivandrum. Krishnan Nair sir was the shrewdest person who had a good vision, and that's why RCC came up. When I went for my interview, lecturer interview, tutor interview, Krishnan Nair sir was there in the interview ward. And the other person sitting behind was my professor then, Dr. Moideen Kuti. I was doing DMRT at Calicut that time. Your professor told me that he is going to buy a Selectron. What do you know about Selectron? Actually, Moideen Kuti sir was a good clinician and good radiation oncologist. But he did not know many things about the modern things. That time, Selectron was a new thing. But the physicist there, Shankaran Nair sir, He said that, sir, we will purchase a Selectron and this has got this such advantages. Immediately, sir said, we will. And he went after that, he got the government order to purchase a Selectron in Calicut Medical College. But being shrewd, Krishnan Nair, sir, took that away to RCC Trivandrum. So first Selectron went to RCC Trivandrum. So, learn good things. Maybe shrewdness, but good things from your seniors and colleagues. And your junior colleagues also can give you a lot of ideas. Never lose an opportunity to get involved. As I said, be a part of the decision-making team if you are invited or you can be part in. You build a team with you. Because you cannot do everything yourself. You build a team. There are so many funding sources. In government, mainly the state government budgetary allocation, for which you may have to run after. Shabari got 20 crore rupees in this budget for his cancer center. Central health sector funds are the most important, where you get funds for purchase of machinery. MP and MLA local administration development funds, very important. For small things like, when we required some fund for Kottayam Medical College, I approached the MP. He said, no problem, I can get you funds. Not from his fund, he did not have that much fund. I said, I will get it from my friend. He, HK Dua, he was a Rajya Sabha MP, nominated MP. The nominated MP has got one advantage. He can spend his money in any constituency in India. The elected MP can spend his money only in his constituency. So the nominated MP from Haryana, who is a friend of our MP, gave us 25 lakh rupees for development. Understood? So they are all very important. Small things MLAs also can do and get funds from the state administration. Other institutions, CSR fund and other agencies, NGOs or other agencies, the Cancer Care Center in Kottayam is the first building in the whole of Asia which was completely constructed with utilizing public money only. Public donations only. Not even a single pie from the government. That time it was around 2 crore rupees. That is a huge amount in 1992. So, such things, there are people who are ready to donate money. There is another institution in Pediatric Institute, Kottayam. A building was donated by a person in memory of his child who died of leukemia, a leukemia center. I think a 3-storied building that is still there in Kottayam Medical College, attached to the Pediatric Institute. So there are people, if you look around, there are people who are willing to help. Where you need the money? You need money for infrastructure development, that is building and manpower, equipment purchase, drug procurement. So those are the main things in your career where you will need more money. Building construction. This one depends on whether it is a comprehensive cancer center you are aiming at or a radiotherapy center only. If comprehensive, discuss with all other stakeholders like the medical oncologists and other radiation oncologists, surgical oncologists and palliative care people to develop the building. If isolated radiotherapy center, choose a plan with a smooth outflow, because you should have, say, your OPD, then you may have a CT simulator, you may have a mold room attached or near that, then you have the planning workstation, you will have the machine. The way patient should flow smoothly, your work should, that you should have to plan ahead. And it is not the job of PWD, you should not leave it to the PWD, you will have to have your own plan. You visit good centers or ask people who use this thing and then prepare a good plan. So discuss with your colleagues also, physicists, radiation technologies, nurses, how it should be, where the nursing station should be, where the physicist cabin should be. All these things you have to plan, and you have to plan for and adequate waiting areas, toilets, furniture, etc. for this thing. Because if you do not put these things, items in your budget, ultimately after building this thing, where is the budget for the chairs and tables? There is nothing allotted there. Everything is finished. So the building will remain there unutilized. So you have to plan everything with the limited funds you have. And nowadays, it is before you construct a building, you take the panchayat permission in the proper way. Pushpagiri Medical College is planning to have a LINAC. Their problem is that there is no panchayat number for their building. Long time back, you could do anything. Without getting a panchayat number, nobody is going to give permission to install it. So they are after that, getting number for all their buildings. So take a building. This happened in Kottayam Medical College also. So take proper panchayat. Otherwise, you will not get electricity connection. You will not get water connection, nothing. So you have to go in the proper way. Radiotherapy buildings, the LINACs will replace telecobalts, I think, in future. So even if it for cobalt, you plan for at least a 15 MV LINAC bunker. You may get a cobalt. Later you can replace that and put a other way, because making a bunker costs a lot. So you plan for and in a 15 MV LINAC bunker, you can put a cobalt also. You should have mold room, CT simulator, MRI, contouring and planning station, brachytherapy, theater with full anesthesia setup, and brachytherapy room also for patient. Equipments, LINAC purchase, or prepare a detailed specifications, as I told. Refer model specification. Model specifications are available, or you can ask other institutions. Discuss with your colleagues, those who have purchased LINACs or those who have worked with similar LINACs or better LINACs, and prepare a proper specification. It is better to constitute a purchase committee, including people from other institutions and physicists and from other institutions, physicists and radiation oncologists from other institutions. Madhu is a very shrewd person in constituting such committee. One thing you will have to remember, don't include anybody in the committee who is going to say no to your things. So, you have to take care. Because you can suggest the government that you constitute a committee. I suggest that these persons may be included. Usually they will accept. So, there should not be any ambiguity in your 10 specifications. It may or like that, what you want you have to write specifically, because company people are very shrewd and they will bend the words. So there should not be any ambiguity. Wording should be perfect. Avoid biased specification. Say, if I am asking for a machine, LINAC, with specification which fits in only with a true beam, variant people will know that he is going for my true beam. Then you do not have any lineage for any negotiation. He will not bring down the price. So you can include true beam characteristics, and it is my thing to choose whether it is going to be a variant LINAC or a Electa LINAC. So include both, because we have limited choices. So because in a private it is much easier. In government, you will have to answer some of the questions from which come later on, probably. But it is avoid bias specification. Ask them to give a compliance checklist. I want this item A, B, C. Will you give yes or no answers only? Because they will write an answer instead of that thing, that thing works here, similar to that. No. Whether you will give this item or no, yes or no answers only will be acceptable. Purchase procedures must be perfect. Get everything in writing, because they may offer something, but you should get it in writing, because later company person, that person who negotiated with you may change to another company. Company will say that in our records, it is not there. We didn't make any offer like that. This has happened. And so get everything in writing from them. And turnkey projects may be easier. You give, if you are buying a variant machine, you can ask variant people to make the bunker for that. Lot of administrative things you can overcome. But there are also challenges which will crop up. Like in Alleppey, when I went there, the bunker was there ready. It took nearly 8 months to get the electricity connection. They said that the PWD people told me that because they have shortcuts. But otherwise, they will try to make lot of hindrances like inspectorate license medicanum. 8 months it took. Understood? So, but even then, turnkey may be an easier thing for you. Manpower requirements. When you develop a department, say you ask for a LINAC, then you will have to have sufficient, look at your workload and AERB guidelines. How many physics you should have, how many radiation technologies you should have, what is your workload. So nurses, how many shifts the nurses will be working, how many IP patients there will be, how many brachytherapy, for everything. For you will have to have physicists, radiotherapy technologists, nurses, attenders, sweepers, cleaners, everybody. And you will have to plan that ahead and you will have to request that also ahead. Drug procurement. See, in medical colleges and all, and also probably in health center also, it is your duty to procure the required drug. How much will you procure? You go through the list of drugs, take a list of drugs. You look at the annual requirement, you look at the previous year's utilization, how much you required, and how much shortage was there. And depending on that, you can put a number, how much you can. And always, I'll tell you one thing, when you write adriamycin, 100 vials, you always write in bracket in words also, 100. Because the clerk sitting there, this has happened to many people, clerk sitting there in collusion with the company can put one more zero and make it 1,000. And you will be questioned why there is surplus drugs here, getting wasted, and that is a big headache. Understood? So always, when you put a number, write in brackets in words also. Because you are a responsible person. So, intent in proper time. There is a time limit given by government. Usually the intent should be given before, say, March 31st. You give it before that. Periodic review of the stock can be taken. Suppose some of the drugs is slow moving. Much are remaining in your stock, not moving as you expected. Some are in shortage. You can always tell your other institution that I have excess of this drug and transfer to other institution. It is not difficult in government. Or you can get medicines from other institutions where they have excess. It is not difficult in government. Rather than expiry and getting wasted, nobody will tolerate and you will be answerable. Relationship. Keep good relationship with the local MLA and politician, MLA, MP and politician, the district collector, the local administration, panchayat, political leaders, our office staff and the local NGOs. Many times they will come to your help because you may be in trouble sometimes. If you are in good relationship with many of these people, then they will help you. Or for your requirements also, they will be able to help you in many ways. Meetings and presentation. You may be asked to attend a meeting. You may be deputed to attend a meeting. Go well prepared. Study the thing which you are going to present there, and if possible, if it is a meeting, if possible, make a short PowerPoint presentation, because in radiotherapy, many things which we say, brachytherapy, teletherapy, telecobalt, LINAC, these things are not going to, they're going to be there. You make a picture of a brachytherapy machine or a treatment patient getting treatment with the brachytherapy, and this is the thing which we want, and this is the way we can cure the patient. They will understand and say in layman's language and follow up the matter. This one has worked well with me at Alleppey. Because in presentation with the district collector and the MP, this has helped me a lot, because they were impressed by my presentation, saying that these are the things which you want. In pictures and in small PowerPoint presentation, I could do that. Income generation. It is very important. Try to get a separate account for your department. This is where I did something in Alleppey. Alleppey, for the decision, the medical colleges generate income. We have the Karunya Pathati with us. And at that time, in Karunya, 40,000 rupee was the amount which we could charge a patient. 1,000 patients were there in Alleppey getting radiation every year. So 40,000 rupee, I made a PowerPoint presentation in one of the college council managements, hospital council managements, where the district collector and MP were there. I said that 40,000 into 1,000, it's a big amount. Sir, that amount should come to a separate account. We will not be charging the patient even a single pie. We will be giving free treatment to every patient. But this account should come to a radiation therapy fund managed by the district collector and the hospital superintendent. And from this, the LINAC, the annual AMC, annual maintenance charge was around 35 lakh rupees. Otherwise, where are you going to find the 35 lakh rupee? This should come to that. For the hospital administration, you can take 50% of that. Rest of the amount I will utilize for appointing probably additional staff on contract basis or repair of equipments, purchase of accessories, etc. And they were impressed by the thing, immediately gave a sanction for that. And that account was opened, even though there was objection from the office staff, that account was opened. And still in that account, I think more than 1 crore rupees there. So this can be, if you convince the administration, you can do something like that, because you will require a lot of money for maintenance of Linux and Cobalt. Media and publicity. Have good relationship with media people. Can bring items of importance to authorities through them. Should never be criticizing comment. Should never criticize the government or your management through media. Should never be for your personal gain. Enne thanne pokkan vendittu njan media ide mumbil vannittu oru divasam you will get pani kittu. Angane pokkunnavarkku. So be in good relationship with them. Maintain discipline. General discipline in the department, USP a role model. Correct mistakes. Do not scold or quarrel with anybody. Report serious offences. Have an idea about Kerala state service rules, KSSR, disciplinary procedures, etc. when you are in, because if you take a disciplinary procedure against a person, it has to be through the proper way. Otherwise, that will not reach anywhere. And the most important things to remember, in radiation oncology, there are 4 crucial players. Oncologists, physicists, technologists, and supportive staff, including others. All are important for smooth running of the department. You are the captain of the ship. Your service is going to be long in the run. And you will meet the same person again. Thrissur, I was posted 4 times. In my whole 33 years, I was posted to Thrissur. My service started in Thrissur. And I was posted 4 times in Thrissur Medical College. So you will meet the same people or similar people again and again. Be in good relationship with them. So be, as Madhu said, be in good relationship with all your physicists, all your technology staff. They can teach you, and if you quarrel with them, then the department development will become a big problem. Thank you.
Thank you, Dr. Jostom, for your excellent narration of the challenges which we are likely to face in, especially in a government setup. It is well explained. I still remember the one point that when we were to purchase the first linear accelerator in a government medical college in India, there was a committee of 25 experts from all over India. And finally, the 25-member committee decided to purchase the machine, and then they all registered their comments, everything. And there were fights between two companies, and for some time this was lying idle in the hospital, in the college administrative section. But the central government audit party came and found that the entire process was done meticulously, and they said this should never be retendered, and thereafter the Kerala government could not go back, and that was why ultimately the machine was purchased. So it is very, very important for us to have a committee consisting of as many experts as possible, especially in government setup. So that is very important. And also remember the specification of the cobalt unit. That time the companies will be trying to cheat. And the first cobalt unit in the whole of India to have a free float couch was that of Kottayam Medical College. Because the company people, they never used to let us know about the intricacies of the specifications of the table, etc. Accidentally.
And the laser back pointer also.
Laser back pointer, they were cheating. They are simply cheating. They want to sell something and take the money. So all these things we could get because there are product catalogs for each and every part of the equipment. Even for the table there is one, back pointer there is one, laser system. So accidentally it fell down, and he could grab that, and then he found that there is a separate specification available for the couch. And that was how we could get the first cobalt unit in India with a free float couch. So it is important. It is very, very important for you to learn the machine in detail. And unless you do that, your physicists, they will take upper hand. So you have to study all these things. You have to burn midnight lamps and study everything and prepare a proper specification.
So for people working in the government setup, should use the government schemes properly. You have plenty of money pouring through these schemes. When we were in Thrissur, what we did was we make every patient sweep the card properly, and no money should be wasted. And all money that is gathered there is, as Sir said, it is kept as a separate account. That is one thing. Another thing is, you should, as Sir explained, you should have a good vision. That is very important. Okay, and if your intention is good, people will accept you. What you speak to other authorities and all, they will accept. And you should have a good rapport with and good communication skills with your administrators, your seniors, and the district collector, especially if you are planning to develop a center at that area. Okay. And for people who are working in government sector, you have training schemes. In the Department of Personal Training gives schemes for, that is training for those who are working in the government setup to do things properly. Then Institute of Management Government, Trivandrum is also arranging certain training courses for faculty in the government medical colleges and the health services. So with all this, and if you have an opportunity to train in any hospital administration or management, we can utilize that also. So thank you, Joseph sir and Madhu sir, for the excellent presentation and interpretation of facts.
Thank you, sir, for that excellent presentation. I request the chairpersons to hand over a token of appreciation to Dr. Jostrom. I now request Dr. C.D. Shivanandan to hand over a token of appreciation to our esteemed chairpersons. Thank you, sir. That brings us to the end of the events here in Hall B. The valedictory function will begin in Hall A shortly. I request everyone to proceed to Hall A for the valedictory function. Thank you, everyone.